Top Bed Talk.
Good afternoon, everyone. This session is our Perioperative Quality Initiative session. You'll hear more about what the Perioperative Quality Initiative is during the course of the session, and it's a pleasure. All 5 of the directors are here. So, TJ, if you would mind introducing yourself and sharing the first presentation. Thank you.
Thank you very much, Mike. Good afternoon, everyone. As Mike said, I'm going to tell you a little bit about the background before the 3 other speakers are going to tell you about the most recent POQI. So as a background, I'm from Stoney Brook in New York. I was originally trained here at the Royal London, or used to be called a London Hospital, and then went on to Middlesex and UCH rotation, and then went on to Royal Free, and then left for the States in the 90s, and come the professor and chair at Stoney Brook in Long Island, New York, and as a founding president of American Society for Enhanced Recovery, and going to tell you about POQI. So what is Perioperative Quality Initiative? So this is an international multidisciplinary non-profit organization. It really started, just to give you a bit of history, there is another organization called Acute Dialysis Quality Initiative, or ADQI, which was formed in 2000, and then later on it changed its name to Acute Disease Quality Initiative. And that organization is predominantly get a group together, come up with consensus guideline, consensus statement, really just to help practicing clinicians trying to analyze, busy and really doesn't have time to get all the evidence together. And some of their work has been, disseminated, published, and I guess probably one of the most well-known to the audience is the RIFLE criteria, which came out of one of the ADQI. And so we thought that, well, there is a lot of evidence out there in regards to perioperative medicine. And so we thought, well, let's organize this organization, POQI, and it's to really trying to look at, again, similar objective is to come up with a consensus statement to help busy clinicians. And this is really focused on perioperative medicine. And so the order of the how it was done is that, we use a modified Delphi process. And each of the POQI conference is divided into a pre-conference, conference, and post-conference work. And the pre-conference is when you get a group together, review the literature, generate bibliographies, and identify a list of questions to be answered. Usually we break down into subgroups, depending on what are the important questions. Most of the work is done before the conference, and in fact, there is a draft consensus that is brought to the conference, so that, in fact, usually is about 4 to 6 months work before each conference. And when the conference is essentially a 2.5 days meeting where we get a group together and debate on the various statements. So usually it's sort of broken into a smaller group, deliberated, come back to the larger group, again, debate, vote, and then trying to refine those statements, and then they go back to the small group again. And we do that a few times until we get to a final statement that is usually agreed upon, but if not, there's, again, doesn't have to be unanimous agreement, and if there is any dissent, then there's a process to manage those dissent, and if there is a certain number of dissent, we record that. And then once the conference is over, this would then turn into a manuscript, and again, I will show you some of the manuscript been published. And the other unique thing about the manuscript is that we have able to get free access on all the POQI manuscripts, as well as infographics, which is available. They are all available on the POQI website. So just to run through quickly the POQI conferences that we had so far. The first one was organized back in March of 2016. And during that time, enhanced recovery started a few years back in the States, and obviously there's a lot of evidence generated not only in the States but across the world, and UK obviously have been a few years ahead of US as far as enhanced recovery. So we examined the various topics of enhanced recovery, fluid management, analgesia, prevention of infections, and also improving the enhanced recovery pathways. So that was our first POQI conference. And we published 6 articles in Perioperative Medicine. In the same year, at the end of the year, there were a few other topics which weren't covered, which also relate to enhanced recovery in the first conference. So this one we carried on with the same theme of enhanced recovery, but this time covering gastro-GI dysfunction, nutritional screening, as well as patient-reported outcome. And again, there was a substantial outcome of that is 6 manuscripts with 3 editorials altogether with 6 manuscripts, also a front cover of ANA journal. So these are some of the manuscripts for the consensus as well as editorial. The third POQI was conducted here in London. In fact, outside, this is the picture outside Montague Garden Hotel. It was focused on perioperative blood pressure and again examining the various topics within blood pressure physiology, pre-op, intra-op, and post-op blood pressure risk, goals, and outcomes. And again, that was the output of that was 3 manuscripts with an editorial. Followed on that, at that time, there was a lot of discussion about opioid use perioperatively, opioid abuse. So we focused POQI IV mainly on opioids and perioperative medicine, mapping out the burden, opioid-free anesthesia, what was the evidence of that, and especially those patients who have chronic pain, how do we manage post-operative care. 3 publications that came out of that was published in ANA together with an editorial and an infographics in ANA. I also made to the first front page of the journal. POQI I was focused mainly on fluid, really on fluid physiology of fluid dynamics, electrolyte homeostasis, some of the fundamental concepts. Again, those of you who are really interested in the physiology of fluid, there's a lot of good information in this consensus. It's almost like a big review article and also a lot of good figures and infographics. POQI VI, we focus on neuromonitoring, focusing really on deliriums and how can we potentially monitor it, how can we reduce that. That was in 2018, and that was accompanied by 3 manuscripts that was published, in particular looking at delirium, monitoring, what are the ways you can reduce that. Followed by POQI VII. Now, POQI VII, we collaborated with the ADKI. It was their 24th conference, and the topic was acute kidney injury in the perioperative environment, and that was done in Cambridge, and that was accompanied with the output was in the Nature Review Nephrology that was published just last year. We had a POQI VIII meeting just last year in Sacramento in California. We collaborated with the ERAS Cardiac Society and examining certain topics within enhanced recovery in cardiac surgery, notably blood management, acute kidney injury, as well as opioid minimization. And the 3 manuscripts are currently in various stages of submissions. Some of them have been accepted. So that is really the POQI until 8, and we are planning for future meetings. Some of the more notable impacts that has been made to some of the manuscript top 10, either in BJ as well as anesthesia and analgesia. And those of you who want to learn more about this organization, there's a website, poqi.org, and there you have all the papers that I've just shown you, plus all the infographics, and all these are available free access, and these are some of the infographics that is on the website that you can all access. And I think one of the challenges is that some of the articles, as you mentioned earlier, that it was either not available freely, and we want to make sure that all the readers around the world can access it with the evidence. So we want to, usually the agreement with the journal is that they have to have free access before we publish it. So in summary, this is the organization is just to generate the consensus statement and offer recommendations. And this is unique because often you read trials or meta-analysis and you read to the end and you want to sort of see, okay, what should I do? And then the last sentence always say that more study that needs to be done, right? And he said, you felt, okay, I want to learn something from here. I think one of the things that we try to do is to really, given whatever information we have, and again, the evidence cannot be 100% complete because we generate evidence as we go by. Think about this, we talked about fluid management has changed over the, since Dr. Brenstruck doing her study, we have changed enormously. So given what the evidence we have, what is the recommendation, and then we can generate new evidence coming along and we can change our recommendation. And so far we have 26 peer-reviewed publications in high-impact international journal. Obviously we explore other topics, and if you have any ideas of new topics I think we should look at, feel free to let us know. Thank you very much for your attention.
Very much, TJ. Pleasure to introduce Tim Miller, who is going to talk to us about POQI I, and then we'll go through POQI II and POQI III, and then we'll have an opportunity for some questions. So, Tim, thanks very much.
All right. Thank you very much. And I get the oldest POQI I, to speak to you about POQI I, which is from 2016. As TJ mentioned, the first POQI focused on ERAS for colorectal surgery specifically, and we tried to do this just to narrow the topic for the recommendations that we're going to have, not to have too large a topic. Important disclosures: I'm the past president for ASA, who sponsored this first POQI, and obviously I'm also the board member and current secretary of POQI itself. So I'm the person who will get the email if any of you want permission to use any of the infographics for another manuscript, for anything that you want to do. We want these manuscripts and infographics to be available, so please contact us if you do as we go along. So as TJ mentioned, POQI I's in my hometown, which is now the last 15 years, Durham in North Carolina. I work at Duke, and I had the pleasure of hosting this and putting together this panel of international experts, surgeons and anesthesiologists to cover these four main topics: fluid management, analgesia, nosocomial infection, and very importantly, I think, measurement and quality. How we measure what we do, which I think is a crucial, any of you that started enhanced recovery pathways, how we measure the impact and the quality of the care that's been given, I think, is very important. Just to briefly mention ASA, this is their website, and we thank them very much for sponsoring this first POQI. So these are the papers that were produced. The fluid management was led by a couple of anesthesiologists from the US, Bob Thiele and Karthik Raghunathan. The two analgesia manuscripts were led by Matt McAvoy, who's a Vanderbilt anesthesiologist, and also Mike Scott, many of you may know, was at Guildford for many years and is now over in the States. And measurement and quality manuscript was led by Ramani and Mike Grocott, that I'm sure many of you know and are obviously experts in this area. Finally, the postoperative infection manuscript was led by two surgeons, Stefan Holibar is now at the Cleveland Clinic, and Tracy Hedrick, who's in the States as well at the University of Virginia. So let's go through these briefly. Obviously, I'm not going to present the entire manuscript, so I'm trying to give you a flavour of what we're trying to do with these meetings and statements. And as TJ mentioned and Andy in the last session, we're trying to give practical recommendations to get off the fence, to give recommendations either based on the evidence in which we will grade them, or if the evidence is weak, then it is sometimes going to be expert opinion of these 25 folks who are in the room, and we'll obviously state that in the manuscript. But we're really trying to help the practicing clinician. So, for instance, these are some of the questions that the group thought were important in the fluid manuscript. And these are sort of questions that you wouldn't perhaps get in a typical systematic review. What are the effects of the carbohydrate drink? Does mechanical bowel preparation contribute to hypovolemia? The urine output question, we heard a little bit about that in the previous session. And what is the rational approach to intraoperative fluid management? These were some of the questions. There were many more. Obviously, I can't present them all. But just briefly to look at some of the recommendations that we came out with, we did recommend as a group that a clear fluid be used to maintain hydration with a preoperative carbohydrate drink, and we suggested that there should be complex carbohydrates when available. We recommended against the use of hyperosmotic or hypoosmotic bowel preparation, since there's no benefit, and there may be adverse effects. You may think, why am I recommending bowel prep at all? We'll come on to that later on. There may be some differences across the pond in terms of the bowel prep debate. In terms of oliguria, we recommended that in isolation, intraoperative oliguria should not trigger fluid therapy, as low urine output is a normal physiological response to surgery, but it should not be completely ignored. It should be investigated as you normally would. And finally, coming on to our sort of hemodynamic framework, we recommend, it's very straightforward, that you should use a hemodynamic framework to guide clinical decision-making during surgery. And this was the sort of first infographic that was produced. Again, simple, but I think the message is important. Is there a clinical problem? Don't use fluid responsiveness in isolation, but try and determine what the clinical problem is. You use that strange blancmange-shaped thing, which is meant to be a brain. You use the information that you have, which in higher risk patients should be advanced monitoring with stroke volume, cardiac output and stroke volume variation, and then you treat to reverse the problem. And I think this has stood the test of time. I think fluids should go first, and as Monty alluded to, I think the use of vasopressors in the last 5-10 years, particularly with the hypotension story, has increased, and perhaps we can come on to that in the discussion. But very much should be fluids first, and then patients that are still hypotensive, then you could add in your vasopressor, similar to the Fedora study. And in those small percentage of patients that have decreased cardiac output, I think in Fedora it was around 3 to 4%, you may want to add an inotrope to increase your contractility, and then of course you want to repeat. And this was another infographic looking at the goal-directed therapy algorithm, taking into account the patient's whole journey. I'm not going to go through it in too much detail, but as I'm sure you're aware with enhanced recovery, minimize NPO, risk stratify, use appropriate monitoring, and really continue this post-operatively, get the patient eating and drinking. And I'm delighted to see more manuscripts coming out recently referring to dreaming, drinking, eating, analgesia, moving and sleeping. I see Henrik Kellett wrote an editorial very recently about this. A very simple marker of recovery in the first 12 to 24 hours after major surgery that's very much being advocated by POQI. So moving on to the analgesia manuscripts, there's a lot of detail in these two manuscripts, but really the key message that we wanted to get across is what is optimal analgesia. That when we're delivering our analgesic plan for patients, and perhaps this was more relevant in the US than some other places, we're not trying to aim for a pain score of 0. We're trying to aim for optimal analgesia that facilitates recovery, optimizes patient comfort with the fewest side effects, to enable the patient to do the drinking, eating, mobilizing, and sleeping post-operatively. And if that's a pain score of 3 to 4, the patient's comfortable, they can eat, they can mobilize, that's a good place to be. And we actually use this infographic in our pre-op clinic to try and help with patient education. And obviously how you do that is going to be very institution, very procedure specific. But we have this basic algorithm at the top there. You want to educate your patient, you want to set the expectations, you want to reinforce those expectations. You have your oral IV analgesics, non-steroidals, acetaminophen, gabapentinoids were here in 2017. I think when we redo this POQI, obviously there's been some literature that gabapentinoids are associated with respiratory depression. We have now removed them from our pathways at Duke. And then a lot of blocks and other adjuncts. And importantly as well, and this is a theme of POQI that we'll come back to, is a rescue plan for suboptimal analgesia. We all try and do perfect perioperative medicine, but we all know that not all of our patients are going to go down the perfect pathway. We're still going to have patients in pain. We're still going to have patients with urinary retention, with post-op ileus. And it's important we have plans to treat these whilst keeping with the principles of good perioperative medicine. So we put together a very simple infographic for suboptimal analgesia. And again, essentially assess the pain and treat using all non-opioid options first. Have your typical pyramid where opioids are at the top, and there were things that some patients need opioids, but we should try and use all other treatments before we necessarily turn to opioids. So the infection manuscript, you may think, why do we do an infection manuscript? I think in the US, surgical site infection is very much a quality metric and is measured, I think, a lot more than it is over here, at least speaking to Monty, Mike and others. So how do we prevent surgical site infection? How do we prevent pneumonia and aspiration? UTI was the third one, and finally CLABSI. I'm not going to mention CLABSI again, catheter-associated infection. Essentially, we just said, put them in as little as you can and take them out early. So what about SSI? We had a lot of debate around bowel prep. I say this was led by 2 surgeons. The recommendations were that we implement infection prevention strategies, a bundle, for surgical site infection as part of our colorectal pathways. We recommended the use of combined isoosmotic mechanical bowel prep with oral antibiotics. We didn't recommend use of bowel prep without antibiotics, and we recommended against the use of the hyperosmotic bowel preps. So the bundle, this is a typical bundle, and we have a bundle at our hospital to try and prevent surgical site infection. And again, you want to individualize this to your hospital, but essentially, preoperatively, as you can see, smoking cessation, preoperative shower with chlorhex, diabetes optimization, anemia optimization, all kind of sensible measures. Intraoperatively, prevent hypothermia. We reduce unnecessary traffic. We have a separate fascial tray for closure, which has been implemented about, I think, 6 to 7 years ago at our institution. And then, post-operatively surveillance and maintain blood glucose less than 180 is the sort of typical elements within our bundle. In terms of the bowel prep argument, this was the main study that has been published in the Annals of Surgery a few years ago now by some surgeons, some of whom are at Duke and work very closely with NSQIP, the National Surgical Quality Improvement Project. So this was a retrospective study, but over 8,000 patients, and see the group that had the mechanical bowel prep with the oral antibiotics, so they're delivering oral antibiotics to the site of the surgery, which is the green group, had a significant reduction in surgical site infection, as well as, interestingly, other post-operative events such as ileus, anastomotic leak, and 30-day mortality. Hence the recommendation that we should use mechanical bowel prep with oral antibiotics, which is what our current practice is at Duke, obviously led a lot by our surgical colleagues. Just moving on briefly to prevention of pneumonia and aspiration, the recommendations were fairly straightforward. Risk assessment, lung protective strategies, and obviously we went into more detail in the manuscript, against the routine use of nasogastric tubes. And we started to mention post-op ileus, that this should be recognised early and treated, and this sometimes will include the use of a nasogastric tube. And we'll come on to POQI II when we went into this in a lot more detail in terms of algorithms and pathways that we recommended. UTI was the third one that we looked at, and we really looked at the sort of relationship between post-op urinary retention, obviously needing a catheter, and UTI. And again, recommendations fairly straightforward that the catheters should be removed early, but I think the second one is perhaps a little bit more useful for hospitals that are trying to get catheters out early and haven't done previously, that if you do fail, if you do have some post-op urinary retention, recommend just a sort of a intermittent cath for 24 hours rather than reinserting that urinary catheter. And the final manuscript useful to publish was about how you measure the quality of enhanced recovery within your pathways. And I think this is generally poorly done. And say Mike and Ramani led this. And I think it was a really nice example of putting a group together to see what they can come up with in terms of recommendations. They really didn't have any it was a kind of a blank slate when they came into the room, and they came up with some recommendations. For research, I think it's fairly straightforward. You should use the COMPAC or the STEP guidelines, which have now been published. But for improvement, I think they decided there should be 3 layers of what you measure. So there's your best practice data set, which is sort of your core data set that all hospitals should be able to use. So this is your length of stay, your mortality, straightforward things, whether you're on an enhanced recovery pathway or not. Your quality improvement data set is the sort of second tier, much more comprehensive, different elements of the pathway, whether you have compliance with that, etc. Now, and perhaps you should do this once or twice a year, perhaps with 20% of your patients, to try and look at quality improvement through your pathway. And finally, your best practice data set. And this is the comprehensive thing, that if you're using something like NSQIP or PQIP in this country, you can put your variables in, you'll have a dedicated support that can enter this, and this is much more comprehensive. So for all of these data sets, you would look at demographics, you want to look at your process measures, and of course you want to look at your outcomes. And those outcomes should be clinical, they should be things like patient satisfaction, and the patient experience, and there should also be resources and economic outcomes. So this is really summarized in this measurement matrix. As you say, you've got your core data set at the top, age, gender, ASA, protocol done or not, and then straightforward outcomes. Your quality improvement data set in the middle, much more about adherence, more about specific outcomes such as the dreaming outcomes, and finally, obviously at the bottom, your best practice data set, much more comprehensive. That is POQI I. Thank you very much.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.